that have caused many pandemics. The SARS coronavirus came out of Singapore in 2004. The MERS coronavirus came out of the Middle East in 2012. Neither of those were as infectious as the current COVID-19, but they were far more fatal. They're about 5 times more fatal than the current coronavirus. The fact that we have a vaccine so quickly is really due to 2 things. One, these vaccine platforms have been in development for 20 years or more. So these vaccine platforms, these sort of general approaches to getting a vaccine are not unusual, but the genetic sequence for COVID-19 was completed last January, in January of 2020. So we've known what the genomic component of this virus is. The virus is actually fairly wimpy. It's a sack of fat with protein spikes on the outside. That's the crown that you see, and a single strand of messenger RNA inside. That's its genetic material. When the virus gets into the body, those protein spikes attach to a cell. It injects the genetic material into the cell. That genetic material takes the cell over, replicates the virus. The cell bursts, puts more virus out into the system, and that virus goes on to infect more cells. That's how it works. There are 2 predicates that will determine whether or not you get infected if you're exposed to the virus. One is the number of virus particles you're exposed to. The other is the amount of time that you're exposed to the virus. This virus is 3 times more infectious than any other respiratory virus we've ever seen. The maximum time for exposure before you will be infected is only 15 minutes. So I want you to think about that in terms of a worship experience. Even if you've cut your worship time down in half, you've already hit the 15-minute exposure halfway through your 30-minute worship experience. The infection rate in the United States is about 15 times that of the rest of the world. We do not have this under control in the United States in any way, shape, or form. We are now at about 1 in 11 people infected in the United States. There are hot spots of more infectivity than that. Some of that is variant. Some of that is just the mask mandates being removed. California, LA is at 1 in 5. Florida is at 1 in 5. New York City is about at 1 in 5. Right now, there are about 1,600 deaths per day and about 50,000 new infections per day. That's about 1 every 2 seconds. And we'll talk about that when it comes to talking about really opening up. This virus is really insidious for 2 reasons. One is that 40% of those who get the virus can still be infectious and shedding the virus, but they're completely asymptomatic. They don't know that they have it. All of those temperature scans that restaurants and things do are useless, because if you're asymptomatic, you don't have a temperature. The other thing is that for those who will go on to develop symptoms, those other 60%, you can be pre-symptomatic and still shedding virus and still infectious for up to 8 days before the symptoms emerge. So again, if you think about that in the context of worship, that could be 2 consecutive Sundays. So this is really a virus that gets very hidden very early on. The other reason this virus is insidious is that it's not a very highly fatal virus. The flu is about a 0.1% fatality rate. This is about 10 times more. It's 1% fatality rate. Something like Ebola or Zika or even SARS were about 5 times that, about a 5% or more fatality rate, some of them up to 50%. Right now, the World Health reports more than 120 million confirmed cases of COVID-19 globally, with about 2.7 million reported deaths. Every country in the world is affected. There is none that has been exempt. In the United States, we are almost at 30 million confirmed cases and 541,000 deaths. That's more than US deaths from World War II, Vietnam, and Korea combined. We also, per capita, are way above our allotment. So right now, we're at 26% of all global infections and 20% of all global deaths. And we've got 5% of the global population. So we do not have this under control in the United States. It took us 4 months to get to 100,000 deaths. It took us 3 months each to get to 200 and 300,000 deaths. And then it only took 1 month to get to 400 and 500,000 deaths. The death rate has accelerated. Right now, a person dies from COVID about every 15 to 20 seconds globally, according to the World Health. The other insidious piece of this virus is really twofold. I talked about the asymptomatic rate. There was a study done in August, right before kids went back to school, in 3 sites around the United States with children ages 4 to 17. Children almost never get symptomatic COVID unless they have some significant underlying medical condition. They experience it at most as a minor cold. However, children ages 4 to 17 carry 25 times more virus in their nasal passages than a hospitalized adult. They are a significant vector of community spread. We're going to talk about that again when we talk about vaccines. The other insidious part about this virus is not its fatality rate, but the morbidity that it causes. Part of that is due to the virus itself. Part of that is due to the fact that it's such an infectious virus. It gets so many places in the body that it actually causes a hyperimmune response. It's something called a cytokine storm. And that causes massive amounts of inflammation throughout the body that can affect many, many organs. So for every one fatality, there are 19 hospitalizations. In the United States alone, that's 62 million people. That's a huge tax on our medical utilization. For every one fatality, there are 18 people who will go on to develop long-term or permanent cardiac damage. The virus gets into the cardiac muscle, but also that hyperimmune response that causes so much inflammation can damage the heart. For every one fatality, there are 10 who will go on to develop permanent lung scarring and damage. I've seen CAT scans and MRIs of young female cross-country runners, some of the healthiest lungs you will ever see, and they are permanently scarred. They will never get that lung capacity back. For every one fatality, 3 will develop permanent kidney damage. 3 will develop strokes. That inflammation gets into the microvasculature, the small blood vessels, and causes blood clots. And those strokes are every age, from age 25 up, not just elderly. There will be 2 permanent neurologic defects, up to and including psychoses, especially in the younger population. And there will be 2 significant cognitive dysfunction. A study showed that long haul COVID fog can actually cause people to lose 9 IQ points. There are long-lasting nerve damages, loss of walking, and then, of course, the cardinal symptoms of loss of smell, loss of taste. The virus gets into the pancreas. It can actually cause diabetes, even if you don't have a predilection for diabetes. It can get into the thyroid and really mess up your metabolism. It's a nasty virus. You don't want it. Trust me. Let's talk about the variants really fast. This is what a virus does. This is not surprising. Every virus does this. When a virus replicates, because it replicates so fast in the body, it tends to replicate incompletely. It essentially evolves on a minute-by-minute basis, absolutely literally. Right now, we know that there are more than 4,000 variants out there. Most of them are less infectious and so will fall away. But those that are more infectious, the ones that we're seeing that are spiking now, become opportunistically the prevalent virus in circulation. The one from the UK is 50% more fatal than the native virus. It's also 5 times more infectious than the native virus. It's in 48 states and Puerto Rico and Guam. By the end of March, it will become the prevalent virus that's in circulation in the United States. And it is running rampant in Europe right now. Italy has really shut back down because of the UK variant. There are 2 that have come out of South Africa that are of some concern. There's 1 that's come out of Brazil that is of some concern. As we've looked at what the vaccines will cover, for the most part, they tend to cover the variants, but at a slightly lower epidemiologic rate. The United States is also producing variants. There's been 1 out of California, 1 out of New York, 1 out of Florida. There's been 1 out of Arizona. And just today, 1 was announced out of France. So these will continue. And these tend to be the ones that are more highly infectious. From a vaccine standpoint, of course, there are 3 that are approved for emergency use right now in the United States. 2 of them are the mRNA platform. These had never been commercialized in the US, but they've been under testing for 20 years. That vaccine takes a snippet of the mRNA, the actual genetic code from the virus, that codes for the protein spike on the outside of the virus, so that when the injection is given, your body recognizes that snippet of protein coding as foreign. And what it does is it primes the cellular immune response to recognize it the next time the body encounters it. So once you get virus in the body, it sees that protein spike, it says, uh-oh, not here, and then it starts to produce antibodies against it. Both of those require boosters. Moderna is 4 weeks, Pfizer is 2. Pfizer is approved for 16 and up, Moderna is approved for 18 and up. Right now, it looks as if the initial deep freeze that was required for distribution and storage is probably not as required as necessary. Pfizer has done additional studies. It can be stored in just a regular freezer, which really helps with distribution and transport. The other vaccine, the J&J Janssen vaccine, is a single shot, is from a different platform. It takes actually the DNA code from the virus for the same protein spike, and it attaches it to an infectious but not virulent virus, an adenovirus. That means that adenovirus will get into the body, it will infect the cell, but it doesn't cause disease in and of itself. So when it infects the cell, it puts in the DNA from the COVID virus, and then that same immune response happens. The body recognizes that protein as foreign, primes the cellular immune response so that the next time the body sees that protein, it'll mount an antibody response to it. All of these vaccines are very highly effective. The J&J one is reported slightly less, but it was also tested later. And so it probably encountered some of the variants that the Pfizer-Moderna vaccines did not encounter in the clinical trials. Both Pfizer and Moderna are already creating boosters against the variants. So you've got to expect that these are going to be annual vaccines. The World Health has declared COVID-19 an endemic virus. That means it will never go away. We will always have it circulating in the system. We'll talk about that a little bit in terms of when we get to talking about herd immunity. What else can I tell you about that? There are other vaccines in the system. AstraZeneca has been discontinued in Europe for concerns about a clotting side effect that has not been proven yet. Cause and effect isn't really known, but AstraZeneca is going to be presenting their data to FDA in the not too distant future. We'll see where that goes. AstraZeneca did not test above 65 years of age, so there's a lot of discrepancy in what these will be approved for, and there are others coming as well. We do not yet have vaccines for adolescents, and we do not have vaccines for under 16. In the United States, 25% of our population is 21 and below. And because, remember, I told you that children are a significant vector for community spread, because we don't have vaccinations for them, this is going to be in circulation for quite some time. Herd immunity is defined as 70 to 95%, depending on how you look at the numbers, of the entire population vaccinated. The reality is we've got clinical trials going on in Pfizer and in Janssen right now for 12 and above. Those trials will not be completed until the end of 2021. Moderna just today announced that they are starting trials for 6 months and above, but it's unlikely that we will have anything for young children, anything between 4 to 16, before the end of 2021, beginning of 2022. Because they are such a big part of our population, we aren't going to get to herd immunity until sometime toward the end of 2021 at the earliest, and it may be the first quarter of 2022. So the broad opening up isn't going to happen on herd immunity anytime soon. CDC has said that that they would issue guidance for a broader opening once we got below 10,000 new infections a day on a national basis. Right now we're at 50,000 new infections a day, so we're not anywhere near that yet. The other thing to remember is, I'm going to talk about the Pfizer-Moderna vaccines because the math is easier to understand. When they came out, they talked about being 95% effective. That's on a population basis. That means literally, statistically, 19 out of 20 people are covered by the vaccine, but 1 in 20 may not be. And so vaccination is not a magic cape. It does not mean that not only are you not immediately immune, it takes 2 to 4 weeks for that immunity to develop after the second shot. But it also means that the CDC guidance that has recently been issued about having full vaccination is one, being misrepresented by the lay press. What CDC has said is that if you have a family group or a small group of friends, small being emphasized, who are fully vaccinated, they're 2 to 4 weeks past whatever the last shot was, they could gather safely unmasked. However, if you go on to read the rest of the CDC guidance, large gatherings are still to be avoided, and anything in public, any large gathering in public still requires masking. They're still recommending double masking and social distancing. So from a worship standpoint, gathering in a sanctuary still requires masks, nothing changes, still requires social distancing. As we've talked about it in the Cincinnati Presbyterian, I've got 3 states, so I've got to cover part of Northern Kentucky and part of Indiana as well. As we look at who's vaccinated and what churches are trying to do, we've told churches you have to go back with the same precautions that you had before. First of all, session makes the determination about building use. That means session has to be the ones who are going to sort of enforce whatever conditions for building use they put in place. If the session says we have to have pre-registration so that we know how many people we can safely distance in our sanctuary, that means you can't let people in if you're at full capacity for your distancing who haven't pre-registered. If you require masks, then you can't let anybody in who refuses to wear a mask or doesn't have one, or you have to hand them one. You have to enforce social distancing. We've also said that while the virus doesn't last very long on surfaces, it lasts 3 to 4 days on an impermeable surface like a doorknob or a light switch, about 1 to 2 days on a permeable surface like a piece of paper. You still want to eliminate as much as you can people walking around the sanctuary and getting close to people. So collection plates and communion plates should still stay in the back so that people can pick up their own rather than walk around the sanctuary